The examination of infants differs from adult examinations, and even those of older children. An examination of this nature will benefit from an efficient sequence of examination, plus the clinician's flexibility to respond to the infant's level of cooperation. You will find that the infant's level of development affects the degree of cooperation. A 3-month-old infant will normally lift the head and clasp the hands. By 6 months, infants normally roll over, turn to voices, and reach for objects, including those in your hands. A 1-year-old may be standing and putting everything in their mouth, including any equipment you might set down within their reach. Temperaments vary. Some infants respond positively to new stimuli, including you. Others may respond to you intensely or negatively. You can increase the chances of obtaining cooperation by considering the following tips. Try to examine infants 1 to 2 hours after feeding, when they are most responsive and liable to be less cranky. Ask the parent about the infant's strengths in order to elicit useful developmental and parenting information. Begin by discussing with the parents any concerns or questions they may have. This is also a time to talk about strategies to optimize the health and well-being of their infant. With the patient's health history in mind, and after good hand hygiene, you are ready for the physical examination. Examine the infant in the presence of the parents, as parents can often help to calm a restless or screaming baby. You can examine the infant in the parent's lap if needed, but an examination table or crib is optimal. Perform a general survey, inspecting the patient closely, literally from head to toe, in order to form impressions for your written assessment. During the general survey, observe the quality of parent-child interactions. Also look for signs of stress or depression in parents, which may place the child at risk, and sometimes can indicate an increased risk for child abuse or neglect. Approach the infant gradually, using a toy or object for distraction. Speak softly to the infant, or mimic the infant's sounds to attract attention. Don't expect to do a head-to-toe exam in a specific order. Take what the infant gives you, and save the mouth and ear exam for last. In general, you will perform non-disturbing maneuvers early in the examination and potentially distressing maneuvers near the end. Follow the general survey with an assessment of somatic growth. Growth is one of the most important indicators of a child's health, and deviations from normal may be an early sign of an underlying problem. When assessing growth, compare your findings with normal values according to the child's age and sex. The most important tools for assessing somatic growth are growth charts. Growth charts display a series of lines that enable you to establish percentile rankings for your patients, indicating their growth relative to other children of the same chronologic age. For safety reasons, it is recommended that pediatric examination tables be placed flush against the examination room wall. For the infant, height is measured as body length. Direct measurement using a tape measure is inaccurate. For a more accurate measurement, place the baby supine on a measuring board or tray, holding the patient still with hips and knees fully extended. Weigh infants directly with an infant scale. Infants should be naked or clothed only in a diaper, in which case the diaper should be weighed separately and that weight subtracted from the overall measurement. Head circumference should always be measured during the first 2 years of life. This measurement reflects the rate of growth of the cranium and the brain. Place the measuring tape over the occipital, parietal, and frontal prominences to obtain the maximum circumference. While blood pressure is routinely measured in children older than 2 years, it can also be obtained from infants, but only if indicated. You will need skills in distraction or play to help obtain this measurement. The most easily used measure of systolic blood pressure in infants is the Doppler method, which detects arterial blood flow vibrations, converts them to systolic blood pressure levels, and transmits them to a digital readout device. You may have trouble obtaining an accurate pulse rate in squirming infants. The best strategy is to palpate either the femoral arteries in the inguinal area or the brachial arteries in the antecubital fossa, or to auscultate the heart. This measurement is important because the heart rate of infants is more sensitive to the effects of illness, exercise, and emotion than that of adults. The respiratory rate in infants has a greater range compared to adults, and in fact may vary considerably from moment to moment, with alternating periods of rapid and slow breathing. In infants, the normal rate ranges between 30 and 60 breaths per minute. Ideally, the respiratory pattern should be observed for at least 60 seconds to assess both the rate and pattern. Because fever is so common in children, obtain an accurate body temperature when you suspect infection. Auditory canal temperatures are considered accurate. The technique for obtaining rectal temperature is relatively simple. Place the infant or child prone on the examining table, on the parent's lap, or on your own lap. Separate the buttocks with the thumb and forefinger on one hand, and with the other hand, gently insert a well-lubricated rectal thermometer to a depth of 2 to 3 centimeters. Keep the thermometer in place for at least 2 minutes. The average rectal temperature is higher in infancy and early childhood, usually 99 degrees Fahrenheit until after 3 years, and may fluctuate as much as 3 degrees during a single day. As you proceed through the examination, and as opportunity arises, examine the skin of the infant carefully to identify both normal markings and potentially abnormal ones. In infants, the skin texture is soft and smooth because it is thinner than the skin of older children. A response to cooling and chronic exposure to radiant heat can occasionally produce cutis marmorata, a lattice-like bluish mottled appearance on the trunk, arms, and legs. Other common skin conditions and rashes include acrocyanosis, milia, miliaria rubra, erythema toxicum, and pustular melanosis. Note any birthmarks in the infant, and palpate to assess the degree of hydration or turgor. Roll a fold of loosely adherent skin between your thumb and forefinger to determine its consistency. In well-hydrated infants, the skin returns to its normal position immediately upon release. Normal physiologic jaundice occurs in half of all infants, appearing on the 2nd or 3rd day of life, peaking at about the 5th day, and usually disappearing within 1 week. Pressing the red color from the skin allows better recognition of the yellow of jaundice. This infant displays no sign of jaundice. When examining the head of the infant, you'll find that the bones of the skull are separated from one another by membranous tissue spaces called sutures. The areas where the major sutures intersect in the anterior and posterior portions of the skull are known as fontanelles. Palpate the sutures and fontanelles carefully, with the baby sitting quietly or being held upright. The fullness of the fontanelles reflects intracranial pressure. In normal infants, the anterior fontanelle is soft and flat. A full anterior fontanelle with increased intracranial pressure can be seen when a normal baby cries or vomits. Pulsations of the fontanelle reflects the peripheral pulse. Assess the symmetry of the skull. Several conditions can cause asymmetry of the skull in newborns and infants. Some are normal or benign, while others reflect underlying pathology. Examine the skull shape from behind. Asymmetry of the cranial vault, or positional plagiocephaly, occurs when an infant lies mostly on one side, resulting in a flattening of the parieto-occipital region on the dependent side. It normally disappears as the baby becomes more active. But plagiocephaly may also reflect injury to the sternocleidomastoid muscle, or premature closure of the sutures, craniosynostosis. Next, check the face of the infant for symmetry. Then, concentrate on forming an overall impression of the facies. It is often helpful to compare the face of the baby with the face of the parent. A systematic assessment of a child with abnormal appearing facies can identify specific syndromes. Percuss the cheek to check for Chvostek's sign, which is present in some metabolic disturbances and occasionally in normal infants. Percuss at the top of the cheek, just below the zygomatic bone in front of the ear, using the tip of your index or middle finger. When assessing the infant's eyes, use subdued room lighting, because bright light causes infants to blink. Newborns keep their eyes closed except during brief awake periods. If you attempt to separate their eyelids, they will tighten them even more. By 1 month of age, an infant should be able to fix on objects such as your face and follow a bright light, provided you catch the baby during an alert period. Examine the infant for eye movements. Hold the baby upright, supporting the head. Rotate yourself with the baby slowly in one direction. This usually causes the baby's eyes to open, allowing you to examine the sclerae, pupils, irises, and extraocular movements. During the first few months of life, some infants have intermittent crossed eyes or intermittent laterally deviated eyes. This can be normal. Look for abnormalities or congenital problems in the sclerae and pupils. Subconjunctival hemorrhages are common in newborns. The eyes of many newborns are edematous from the birth process. Pupillary reactions can be observed either by response to light or by covering each of the infant's eyes with your hand and then uncovering them. Inspect the irises carefully for abnormalities and examine the conjunctiva for swelling or redness. Then, try to use your ophthalmoscope to examine the red retinal fundus reflex. Failure to see a red or orange reflex may indicate an abnormality. Set the ophthalmoscope to 0 diopters and view the pupil from 10 to 12 inches away. Normally, a red or orange color is reflected from the fundus through the pupil. The cornea can normally be seen at +20 diopters, the lens at +15 diopters, and the fundus at 0 diopters. Also, look carefully for retinal hemorrhages. Examination of the infant's ears is important because many abnormalities can be detected, including structural problems, otitis media, and hearing loss. Note the position of the ears in relation to the eyes. An imaginary line drawn across the inner and outer canthi of the eyes should cross the pinna or auricle. If the pinna is below this line, then the infant has low-set ears. While this may be normal, it may also be a sign of a congenital syndrome. The infant's ear canal is directed downward from the outside, so you must pull the auricle downward, not upward, to get the best view of the eardrum. Test for hearing using the acoustic blink reflex, a blinking of the infant's eyes in response to a sudden sharp sound. You should be able to produce this reflex by snapping your fingers or using a bell, beeper, or other noise-making device approximately 1 foot from the infant's ears. Be sure that you are not producing an airstream that may cause the infant to blink. This reflex may disappear after the first 2 or 3 times within a brief period because of a phenomenon known as habituation. The most important component of the examination of the infant nose is to test patency of the nasal passages. You do this by gently occluding each nostril alternately. Because infants are nasal breathers, they should easily tolerate this gentle maneuver. Do not occlude both nostrils at once, however, which would cause considerable stress. To inspect the nose, use a wide speculum and ensure the nasal septum is midline. Palpation of the sinuses of newborns is not helpful. To inspect the mouth and pharynx of infants, use a tongue blade and a light, as well as palpation. One method of examination utilizes the parent to hold the infant's head and arms. Palpate the upper hard palate to make sure it is intact. You may notice small pearl-like cysts called Epstein's pearls along the alveolar ridges or centrally on the hard palate. Epstein's pearls disappear within 1 or 2 months. You may see a whitish covering on the tongue. If this coating has been caused by milk, it can easily be removed by scraping or wiping it away. Try to distinguish milk from thrush, which is also commonly seen on the buccal and gingival surfaces. Pharynx of the infant is best seen while the infant is crying. Listen to the quality of the infant's cry. It should be lusty and strong. You will likely have difficulty using a tongue blade because it produces a strong gag reflex. Do not expect to be able to visualize the tonsils. Begin examination of the infant's neck by palpating. Because the necks of infants are short, it is best to palpate them in the supine position. Palpate the lymph nodes of the neck and assess for any additional masses, such as congenital cysts, including branchial cleft cysts, thyroglossal duct cysts, or cystic hygromas. Next, check the position of the thyroid cartilage and trachea. In newborns, palpate the clavicles and look for evidence of fracture. Carefully assess respirations and pattern of breathing. An important tip is not to rush to the stethoscope, but rather to observe the infant carefully and note respiratory rate, color, nasal component of breathing, and audible breath sounds, including nasal flaring, grunting, audible wheezing, or retractions, known as chest indrawing. Chest indrawing is the inward movement of the ribs during inspiration. Any of these signs of work when breathing indicate respiratory pathology. Percussion is not helpful in the examination of the chest of infants, as the infant's chest is hyperresonant throughout. So assess tactile fremitus by palpation. Place your hand on the infant's chest when the infant cries or makes noise. Place your hands or fingertips over each side of the chest and feel for symmetry in the transmitted vibrations. Next, begin auscultation. Breath sounds are louder and harsher in infants than in adults because the stethoscope is closer to the origin of the sounds. Also, it is often difficult to distinguish transmitted upper airway sounds from sounds originating in the chest. Upper airway sounds tend to be loud, transmitted symmetrically throughout the chest, and loudest as you move your stethoscope toward the neck. They are usually inspiratory, coarse sounds. Lower airway sounds are loudest over the site of pathology, are often asymmetric, and may occur during expiration. Expiratory sounds are generally from an intrathoracic source, while inspiratory sounds can arise from an extrathoracic airway, such as the trachea, or an intrathoracic source. The characteristics of the breath sounds, such as vesicular and bronchovesicular, and of the adventitious lung sounds, such as crackles, wheezes, and rhonchi, are the same as those for adults, except that they may be more difficult to distinguish in infants and often occur together. Before examining the heart itself, carefully observe the skin for cyanosis. The best place to ensure that the infant is pink is to look in the mouth. A true pink, the color of a strawberry, is normal, while cyanosis appears more like the deeper red of a raspberry. Acrocyanosis is important to detect. While it may be a normal response to exposure to cold air, it may also reflect congenital cardiac abnormalities as well as respiratory diseases. Observe the infant for general signs of health. The infant's nutritional status, responsiveness, happiness, and irritability are all clues that may be useful in evaluating cardiac disease. Observe the respiratory rate and pattern to help distinguish the degree of illness and cardiac versus pulmonary disease. While respiratory disease tends to cause work of breathing, cardiac disease in infants tends to cause peaceful tachypnea. Palpate the peripheral pulses. The brachial artery pulse in the antecubital fossa is easier to feel than the radial pulse at the wrist. Feel the femoral pulses, which lie at the midline just below the inguinal crease, between the iliac crest and the symphysis pubis. This is particularly challenging in squirmy, chubby infants, but it is important to assess because coarctation of the aorta can cause absent femoral pulses on the affected side. One trick is to flex the infant's thighs. The infant will likely stretch them out a bit and allow you to palpate in the inguinal canal. You should also try to palpate the dorsalis pedis and posterior tibial pulses, although these may be difficult to feel. Note that the point of maximal impulse is often not palpable in infants. Next, place your hand on the chest to feel for thrills. The rough, vibrating turbulence of thrills within the heart or great vessels is quite rare in infants. You can evaluate the heart rhythm more easily by listening to the heart rather than by feeling the peripheral pulses. Auscultate using the diaphragm and the bell of your stethoscope to evaluate the S1 and S2 heart sounds carefully. They are normally crisp. You can usually hear the second sounds, or S2, at the base separately, but they should fuse into a single sound in deep expiration. A split S2 may be detected in neonates who are quiet or asleep. Hearing a split S2 reduces the likelihood of serious congenital cardiac defects. If S2 is detected, listen for the intensity of the aortic or first component, which is normally louder than the second component, the pulmonic sound. Third heart sounds that are low-pitched and early diastolic may be detected best at the lower sternal border, or right ventricular area. They reflect rapid ventricular filling and not disease. Fourth heart sounds are not often heard in children and are low-frequency, late diastolic sounds occurring just before the first heart sound. You might even hear an apparent gallop in the presence of a normal rate and rhythm. This is normal in infants. Remember that infants breathe rapidly, so you will need to mentally subtract the sounds of respiration from the heart sounds. One of the most challenging aspects of the cardiac examination of infants is the evaluation of heart murmurs. Characterize heart murmurs by noting their specific location. For instance, locating a murmur in the left sternal border is less helpful than describing the location as the left upper sternal border. Listen for systolic or diastolic murmurs as well as third heart sounds. Fourth heart sounds are rare in newborns. Most children will have one or more functional or benign heart murmurs at some point in their childhood. With time and practice, you will improve your ability to differentiate between these murmurs and the unusual or pathologic ones. While examining the breasts of both the male and female newborn, you'll find they are often enlarged as a result of the effects of maternal estrogen. Such enlargement may last several months. The breasts also may be engorged with a white liquid, sometimes colloquially called witch's milk. This finding may last for the first week or two of life. Inspect the abdomen of the infant with the baby lying supine. The normal infant's abdomen is protuberant as a result of poorly developed abdominal musculature. In a very young infant, inspect the umbilical cord to detect abnormalities. Normally, there are 2 thick-walled umbilical arteries and 1 larger thin-walled umbilical vein, which is usually located at 12 o'clock. Look for any redness of the skin around the umbilicus, which would be abnormal and could signify infection. Swelling around the umbilicus is probably due to umbilical hernias, which are detectable at a few weeks of age and tend to disappear by 1 year. You may notice a diastasis recti in many normal infants. This is a separation of the 2 rectus abdominis muscles, causing a midline ridge, especially on contraction of the abdominal muscles. This is a benign condition in most cases. As in adults, auscultate the abdomen prior to palpation. You may note active tympanic sounds because of the infant's propensity to swallow air. It is easy to palpate an infant's abdomen because infants like being touched. A useful technique to relax the infant is to hold the legs flexed at the knees and hips with one hand, while palpating the abdomen with the other. You may also want to request assistance from a parent, or use a pacifier or bottle to quiet the infant in this position. Start gently palpating the liver in infants, low in the abdomen, moving upwards with your fingers. This technique helps you avoid missing an extremely enlarged liver that extends down into the pelvis. With a careful examination, you can feel the liver edge in most infants 1 to 2 centimeters below the right costal margin. It is more difficult to feel the spleen than the liver. The spleen is soft with a sharp edge and projects downward like a tongue, normally 1 to 2 centimeters under the left costal margin. You may be able to palpate the kidneys of infants by carefully placing the fingers of one hand in front of and those of the other hand behind each kidney. In the newborn female, the genitalia will be prominent as a result of the effects of maternal estrogen. The labia majora and minora have a dull pink color in light-skinned infants and may be hyperpigmented in dark-skinned infants. Examine the different structures systematically, including the size of the clitoris, the color and size of the labia majora, and any rashes, bruises, or external lesions. Separate the labia majora at their midpoint with the thumb of each hand and inspect the urethral orifice and labia minora. Assess the hymen, which is a thickened avascular structure with a central orifice covering the vaginal opening. Begin examination of the infant male genitalia with inspection. With the infant supine, note the appearance of the penis, testes, and scrotum. Then, unless the infant's penis has been circumcised, examine the foreskin, which completely covers the glans penis. You may be able to retract the foreskin of the infant just enough to visualize the external urethral meatus. Do not retract the foreskin forcefully. Examine the shaft of the penis, noting abnormalities. Make sure the penis is straight. Inspect the scrotum and testes, making sure you can feel both testes. Note any swelling within the scrotal sac and try to differentiate it from the testes. Familiarizing yourself with the appearance of the genitalia at different ages will help you recognize normal variations from subtle abnormalities. For infants, the rectal examination consists of visual inspection of the anus. Digital examination is not routinely performed unless pathology is suspected. Much of the musculoskeletal examination focuses on detection of congenital abnormalities, particularly in the hands, spine, hips, legs, and feet. Combine the musculoskeletal examination with the developmental and nervous system examinations. The infant's hands are clenched because of the palmar grip reflex. Extend the fingers carefully and inspect, noting any defects. Palpate along the clavicle, noting any lumps, tenderness, or crepitus that may indicate a fracture. Carefully inspect the spine. Major defects such as a meningomyelocele will be obvious, but look also for subtle abnormalities, including pigmented spots, hairy patches, or deep pits, particularly along the midline. Palpate the spine in the lumbosacral region. Examine the infant's hips carefully for signs of dislocation. Two techniques are especially helpful. For the Barlow test, hold the legs as shown and rotate your hands outward, seeing if the femoral head feels stable or moves laterally. Movement of the femoral head signifies laxity and a dislocatable hip. For the Ortolani test, again hold the legs as shown and rotate your hands the other way, inward, until each knee touches the table. A palpable movement of the femoral head back into place is abnormal. It is important to examine the legs and feet to detect developmental abnormalities. Assess symmetry, bowing, and torsion of the legs. There should be no discrepancy in leg length. Some normal infants exhibit twisting or torsion of the tibia inwardly or outwardly on the longitudinal axis. Parents may be concerned about a toeing in or toeing out of the foot and an awkward gait in toddlers, all of which are usually normal. Tibial torsion corrects itself during the second year of life after months of weight bearing. Finally, examine the feet of the infant. At birth, the feet may appear deformed from retaining intrauterine positioning, often being turned inward. Manipulate the affected foot. A normal foot should be easy to correct to neutral and even to an overcorrected position. Scratch or stroke along the outer edge of the foot to see if it assumes a normal position. The normal infant's foot has several features that, while they may initially concern you, are benign. The foot appears flat because of a plantar fat pad. There is often inversion of the foot, elevating the medial margin. The infant may exhibit adduction of the forefoot without inversion, or even adduction of the entire foot. Each of these normal variants tends to resolve within 1 or 2 years. The examination of the nervous system in infants includes techniques specific to their particular age. Because neurologic abnormalities in infants often present as developmental abnormalities, these two examinations need to proceed together. First, assess the mental status during alert periods. If the baby is transiently too drowsy, return at a later time. Assess motor function and tone by carefully watching the infant's position at rest and then testing resistance to passive movement. Assess tone as you move each major joint through its range of motion, noting any spasticity or flaccidity. Hold the baby in your hands to determine if the tone is normal, increased, or decreased for age. You can test for the infant's sensory function only in a limited way. Test for pain sensation by flicking the infant's palm or sole with your finger. Observe for withdrawal, arousal, or change in facial expression. Do not use a pin to test for pain. Testing an infant's cranial nerves requires special methods that differ from those used for older patients. Cranial nerve 1, which mediates sense of smell, is difficult to test in infants. Cranial nerve 2 mediates vision, while cranial nerves 3, 4, and 6 mediate extraocular movement. These nerves can be tested by having the baby regard your face or a moving toy that has no sound. Look for facial response and tracking. Cranial nerves 2 and 3 control response to light. To test, raise the baby to a sitting position to open the eyes. Use a light and test for optic blink reflex. You may also use the otoscope without a speculum to assess pupillary response. Cranial nerve 5 can be assessed by testing the rooting reflex and the sucking reflex. Cranial nerve 7 innervates all muscles of facial movement and expression. Observe the baby crying and smiling while you assess symmetry of the face and forehead. Cranial nerve 8 mediates hearing and vestibular function. Test acoustic blink reflex and tracking in response to sound. Cranial nerves 9 and 10 mediate the sensory and motor functions of the palate, pharynx, and larynx. These nerves are assessed by observing the infant's coordination during swallowing and by testing for a gag reflex. Cranial nerve 11 innervates the sternomastoid muscles and upper trapezius muscles and is assessed by observing the symmetry of the infant's shoulders. Cranial nerve 12 mediates motor functions of the tongue, affecting articulation of words. Observe coordination of swallowing, sucking, and tongue thrusting. The deep tendon reflexes are variable in newborns and infants because the corticospinal pathways are not fully developed. Their exaggerated presence or their absence has little diagnostic significance unless this response is different from results of previous testing or unless extreme responses are observed. To elicit deep tendon reflexes of the biceps and quadriceps, use the same techniques as you would for an adult, substituting your index or middle fingers for the neurologic hammer. However, the triceps, brachioradialis, and abdominal reflexes are difficult to elicit before 6 months of age. Although a normal flexion plantar response is obtained in 90% of infants, a positive Babinski response to plantar stimulation, that is dorsiflexion of the big toe and fanning of the other toes, can be elicited in some normal infants until 2 years of age. Try to elicit the ankle reflex by grasping the infant's malleolus with one hand and abruptly dorsiflex the ankle. You may note rapid rhythmic plantar flexion of the foot in response to this maneuver. Up to 10 beats can be normal, but 1 to 2 beats are most common. The infant's developing central nervous system can be evaluated by assessing infantile automatisms called primitive reflexes. These developed during gestation are generally demonstrable at birth and disappear at defined ages. A few of the more important primitive reflexes include the palmar grasp reflex. Place your fingers into the baby's hands and press against the palmar surfaces. In infants up to 3 to 4 months old, the baby should flex all fingers to grasp your fingers. The rooting reflex. Stroke the perioral skin at the corners of the mouth. In infants up to 4 to 6 months old, the mouth should open, and the baby should turn the head toward the stimulated side and suck. The Moro or startle reflex. Hold the infant supine, supporting the head, back, and legs. Abruptly lower the entire body about 2 feet. In infants up to 4 to 6 months old, the arms should abduct and extend, hands open, while the legs flex. The infant may cry. Abnormalities in these primitive reflexes merit more intensive investigation. There are standardized developmental screening instruments which illustrate the key developmental milestones that an infant normally reaches. These charts can aid you in determining which age-specific developmental tasks to evaluate. By observation and play with the infant, you can do both a developmental screening examination and an assessment for gross and fine motor achievements. Remember that a clear, well-organized clinical record, employing language that is neutral, professional, and succinct, is one of the most important adjuncts to patient care.
Anterior fontanelle is 1 centimeter and soft. Posterior fontanelle was closed. The right occiput showed mild plagiocephaly. Ears were normal with TMs.
After practice and further review of this video, make sure you have mastered the important learning objectives for examining infants.